Hey, good morning. We're going to go ahead and get started. So for our first talk this morning, we're going to learn about early palliative care in the surgical ICU, which I think is an extremely important topic and something I have to admit I am guilty of in terms of engaging in a timely fashion. So I look forward to learning something this morning from Dr. Nohra, who is an assistant professor in the Geitz division. She's a tax surgeon. She joined us really just less than a year ago. She did her undergraduate and medical school at the AUB, and it's surprising what I learned reading through the CVs. As it turns out, we share many common friends at the AUB in Beirut, and after medical school there, she came to the States, did several research fellowships, but did her general surgery training at Florida Atlantic and Henry Ford Hospital. She then went on to do a surgical critical care fellowship at the University of Buffalo, and she's really off to a great academic start. So welcome. Thank you.
Good day, everyone. And thank you, Dr. Schulich. Thank you so much. Thank you so much for the privilege of the podium. Thank you so much for the privilege of the podium, for the generous introduction, and for the opportunity to talk about important principles in the service of our patients. I'm especially grateful as I'm in my very first year of appointment as a university, as you just heard. This talk will provide me professional growth and opportunities. It will serve the goals of the department, hospital, university, and most importantly, our patient. I have placed our Geitz mission statement up here. Today, we'll discuss early palliative care in the ICU. Lots of question marks, right? My presentation has gone through multiple iterations of title selection, partly as I evolve in the materials I plan to discuss, as my connection to others in the department and hospital grows, and as a demonstration of fidelity to the materials discussed, as you probably imagine would occur with continual immersion in the material. At first, I called the talk Early Goals of Care in the ICU, in reference to both the process of engaging in early goals of care discussions and the importance of doing so to achieve alignment with both achievable medical goals and the substituted wishes of the patient. Then, before giving an earlier version of my talk entitled the same and receiving feedback about it, I called the talk Humanity in Surgery and End of Life. And now yet again, my title has changed. You see, palliative care in surgery and surgical critical care does not only encompass the goals and communication of such goals, the recognition of life-limiting illness, and the humanitarian provision of support, empathy, and what we call comfort care. And although the former and the latter are central and quintessential to the provision of palliative care in the surgically critically ill patient is much more than that. With this in mind, I present to you today early palliative care in the surgical ICU. So I'd like to share with you a story. I was meeting with a senior mentor, and she shared with me this patient's story. I would not mention her name because she does not know I'm giving this talk yet. She relayed to me her concern over a trauma patient who had rib fractures and no other significant injuries after a motorcycle crash. He had failed extubation, likely related to pain. She was concerned because his wife vehemently refused a tracheostomy. She found that very strange and somewhat scary, as she could not understand why they would want to give up at this point, although the experienced clinician could discern that the wife was being genuine about the substituted judgment of what the patient would want. What do you as a surgeon and an intensivist, if you are one, feel and think about this wife's choice and the physician's perspective? Please keep that in mind. We will visit this case later on in this talk. Let me tell you another story. A person close to me had bladder cancer at age 80. She was otherwise healthy. It was more advanced at the time of surgery than the oncologist had hoped, and he told her that. She refused any more treatments and any more trips to the hospital. We brought her back to the hospital a few months later with nausea, vomiting, bloat, and constipation, with her assent. She was drowsy at the time, her kidneys were hurting for volume, and she was dehydrated. She was diagnosed with peritoneal carcinomatosis. When she came to, she was approached by a surgeon who was anticipating surgery, likely an ileostomy. She was consented and boarded for surgery. All the while, she had not been told she was going to die. I knew her. When I told her, that she was going to die from the disease as she had failed neoadjuvant chemotherapy and surgery with curative intent. When I told her in the most compassionate way I could, and that the surgery would not change that eventual fact, she went to the palliative care ward instead and was completely herself for a few months until she peacefully passed away. Until then, she talked with friends and family over the phone and prayed a lot, fully awake and with her full cognitive capacities. She was given great medical care. What do you, as a surgeon and intensivist if you are one, feel and think about this patient's choice and the physician's disclosures or lack thereof? Please keep that case in mind as well. We will revisit this case later on in this talk. Okay, 2 patient stories in. What are we talking about here? Are we talking about end of life? Well, are we? Not quite. In fact, end of life is only a small portion of palliative care. So I'll proceed by defining palliative care. The term palliative care can be mistakenly regarded as identical to end of life. Whether we outwardly express it or so, as surgeons, we may internally associate palliative care with giving up on cure or giving up on fixing the problem. Now, although a part of palliative care is end of life, it is only a small portion of patients who benefit from palliative care who will also benefit from end of life care. So it follows logically that the intended exclusion of patients where cure remains possible is imagined and potentially detrimental to our patients. Back to the definition. According to the World Health Organization, palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illnesses. Through the prevention and relief of suffering by means of early identification, impeccable assessment, and treatment of other problems, including physical, psychosocial, and spiritual. I like that, impeccable assessment, don't you? It sounds a lot like critical care, and it describes the needs of our patients too. Up to 75% of patients admitted to the ICU experience distressful symptoms: pain, confusion, discomfort, thirst, anxiety, hopelessness, you name it. And by that definition, would benefit from palliation. The optimal delivery of palliative care directs the care delivered to emphasize and enhance the autonomy, beneficence, non-maleficence, and justice for the patient, and fidelity about prognosis and achievable medical goals. Let's go back to our patient stories. The first was a motorcycle crash who was otherwise healthy with rib fractures, who failed extubation, who was refusing a tracheostomy by surrogate decision. Now, to examine this case from the basis of ethical principles, we are encouraged as surgeons and intensivists that the prognosis, as one might draw on a best case, worst case board, with tracheostomy is most likely survival and discharge to long-term care facility with the likely possibility of clinical improvement, decannulation, and graduation from said care facility. The patient's wife takes this into account. Fidelity about prognosis is satisfied by the sharing of these details, and the autonomy of surrogate decision-making is preserved. The burden of treatment in this case very likely involves dependence and some commitment to long-term care facility, rehab, or both. As the person is someone who never wanted that, someone who wanted to ride their motorcycle until their last breath, the burden of treatment is seen by the wife as too much for the patient. The treatment does not pass the theoretical test of non-maleficence in the eyes of the surrogate. Then let's talk about the healthy but elderly lady with bladder cancer who came in with pain and thirst and was found to now have peritoneal carcinomatosis. The provision of ileostomy in this case preceded the discussion of eventual mortality of the diagnosis and the state of the kidneys and the potential need for dialysis in case of secondary insult. It preceded a discussion of the ostomy bag and the similarities in care burden to the nephrostomies that she only accepted because they were temporary at the time. It was not discussed that she would likely never be independent again. That was a woman who traveled and spent time with her friends and did mountain climbing and all those things. It was simply stated that the surgery would help her at a time she presented with thirst and pain. Here, the fidelity portion was breached. Now, although both these cases ended with leaning more towards end-of-life treatment, there certainly are many from my clinical practice that leaned exactly the other way. That is, after learning about the patient's beliefs and goals, listening well so that I could make recommendations in line with their values and lived experiences, and then sharing all relevant treatments, their benefits and burdens, the patient or their surrogate chose the more quote-unquote invasive set of medical and surgical treatments in parallel with ongoing symptom palliation and support. Almost everyone chooses in parallel with palliation and support. Let us summarize then the what of palliative care. Decision-making, alignment of treatment with the patient goals, emotional support with patients and families, and the basis of symptom management are core elements of palliative care and also core elements of critical care. There is now plenty of data to show that palliative care overall improves quality of life, shortens hospital and ICU length of stay, lowers the caregiver burden, and reduces the use of emergency resources. These data are strong, not only in oncology and oncologic surgery, advanced COPD and heart failure, but in trauma as well. It does not shorten survival. As you can see, palliative care utilization may improve outcomes after discharge in trauma. This is in patients 55 years of age or older. As you can see, early palliative care consultation defined as less than 3 days after admission in trauma patients led to shorter length of stay, reduced ventilator days, reduced number of procedures, and reduced costs. In fact, the ACS TQIP Best Practice Palliative Care Guidelines from the ACS Committee on Trauma, written in 2017, has critical contributors within our faculty, by the way. The move for palliative care in trauma has been progressive since 2008. The whole of palliative care, though, has been born in the 90s. That underscores the importance, of my opinion, as the realm of the possible in medicine has been expanding. And the overall longevity of survival has increased tremendously. But as you might say, just because we can, doesn't mean we necessarily should for certain types and certain instances of intensity of treatment. Each person has their own life to live for sure and their own values for that life lived. And the intensity of treatment available probably behooves us even more to be cautious of its effects. We as a society have a dedication to the overall betterment rather than, for example, working to prolong the inevitable or accidentally increasing pain or longevity unnecessarily. We could talk a lot about all that for sure. Anyway, in the guidelines, there's a pretty good tool for peer review on palliative care integration, specifically in trauma mortalities. And although the call to change culture, for example, has been out there in 2008, in my opinion, this particular message about end-of-life care is only a portion of the importance of the message because it excludes the palliative care in its entirety. Well, now what? Should every critically ill patient have a palliative care consultation? Should every surgeon and intensivist be trained in palliative care? Well, yes and no. There's certainly a big role for the surgical intensivist in the provision of palliative care. There's also a drive to incorporate the provision of palliative care in resident and fellow education. I have it on good authority that palliative care is actually going to be its own EPA for the surgical critical care fellowship. Thus, I would summarize the role of the acute care surgeon and surgical intensivist in the provision of palliative care as follows. 1, the recognition of life-limiting disease and illness trajectories. 2, the alleviation of distressing physical and psychosocial symptoms. 3, eliciting patient goals, priorities, and willingness to make trade-offs to achieve acceptable outcomes, acceptable to the patient, not to us. Engaging specialists and optimizing communication across care teams, and preserving human dignity and autonomy, including at the end of life. Also, disease-specific prognostication is quite important and is at a central role of the experienced surgeon and intensivist, the rehab specialist, and in my opinion, should be prioritized in every research agenda. And so what? Why is this all important? First, 10 to 30% of all people actually die in an ICU. Every human who has lived has a particular set of beliefs, fears, and desires about their end, about how they die. It would behoove everyone to actually think about it for the benefit of their patients. Now, in many cases, surgery has palliative indications, and any type of surgery can be discussed in detail with regards to the palliative indications, the curative indications, and the effect on survival. That being said, while the surgeon is a master of the surgery, the patient is a master of themselves. That is to say, it is different for each patient what they're willing to tolerate and for what possible result. Then, therefore, the surgeon must explore the health states of a patient would tolerate, which helps the surgeon identify interventions which are overly burdensome, overreach survival goals, or undermine the patient's quality of life. The surgeon must incorporate the patient's priorities to make a recommendation in line with those priorities. The good news is that it's usually one of 3 things, as there are limited options: maximizing time on this earth, freedom from pain or discomfort, and independence. Usually one or a combination thereof. But mind you, the conclusions of the different combinations of these components is vastly different for each patient. The bad news is that there's usually a complex set of circumstances involved in at least a skosh of uncertainty, but a good clinician can usually make a sound recommendation in line with the patient's particular balance of these priorities in most situations, in conjunction with a good sense of likely projected outcomes of each route of treatment. It's important to know that surgery is too common at the end of life, meaning that, for instance, 1 in 3 Medicare patients undergo an operation the year before they die. That's based on Medicare data. The evidence happens to suggest that that's not what most elderly folks would have wanted. This is more in primary care to help fix, and also on the surgeon to know that the life-saving drive that was ingrained in us is not shared by the patient, not necessarily. Also, many have chronic illnesses that will not be improved and may certainly decompensate with surgery to fix a sometimes unrelated and possibly futuristic problem. I got asked once by a fellow, by a patient's husband who seemed too shy to ask the surgeon if the tracheostomy that the surgery had offered would fix his wife's lungs. The patient was an end-stage COPD who was already partially dependent on BiPAP and now had a pneumonia. I actually face-bombed in private. But truly, it was sad. So much conversation needed to be had about the progressive dependence on positive ventilation in the future, what life would look like, which had not happened and was not going to happen. The momentum of hospital care. The momentum of hospital care is a wonderful thing. It goes fast. All of it. All the additional medical interventions. One might go from CPAP at night to a trach, a feeding tube, and an LTAC. It behooves us to recognize it and to look out for goal alignment. When the best achievable goal is not good enough for the patient's life rules, and especially when there's no possibility for meaningful survival outside the acute care setting, i.e. the ICU. This particular circumstance of lack of survival outside the acute care setting is where the intensivist steps in as futility becomes immediately relevant. Furthermore, when the patient's values or goals are not clearly known and there's no good surrogate, situations can be challenging. I would say patient participatory research should help illuminate what one should be doing in that circumstance. So for a takeaway, as can be important in a grand round, one might ask, what does excellent palliative care look like in the surgical ICU? That could be a book, but here are some elements I fancy would be present. And the term early for palliative care applies because all of the elements should begin from the moment of admission. 1, identify the healthcare surrogate. Important, right? Informed decisions cannot be made without them. Share prognosis. Use tools like best case, worst case. Get them to know what actually is happening with their loved one. Elicit information about the patient's lived life, goals, and priorities. Get to know the patient. Evaluate the whole entire person. This is where pain specialists, geriatric medicine experts, nutritionists, rehab professionals, and the good old intensivists put their heads together. Chronic critical illness, by the way, is a big thing, and it's nasty, but it's a topic for another day. Explain all relevant treatment options, including non-surgical ones. I get into this a lot about malignant bowel obstruction, obviously. Medical is not always best, surgical is not always best. Keep everyone in the loop and share ideas about how XYZ would help this particular patient. And remove ongoing heartbeat as the only measure of success. Think about the 92-year-old grandma who absolutely did not want to be jolted by the pacemaker, even if she suffered a fatal arrhythmia. This was a news story, by the way. Don't be afraid to consult, use your hospital system, use your consult triggers, APPs, and nursing inputs. Know the limitations of your own knowledge and skill and accept not knowing everything. Engage social work and spiritual care. A great new mentor told me, who also reviewed my presentation, attempt to be the physician that you hope you are or that you'll be treated by. Up there is a sample of the best case, worst case tool. Don't worry, you don't need to be an artist to do this. You would need pen and paper and to draw a series of boxes and stars. If this does not ring a bell, please go to YouTube and review this. It's an incredible breakthrough and wonderful tool in the care of our patients. All you have to do is update it every day, use the most relevant information, and tell the patient a story. Based on the updates in the story, the patient will be in a more clear position to actually see what their goals and values align with. And I move to research. Here are some things coming down from the pipeline from our group. We will ask by matched survey of ICU providers and ICU patient families what their impression of prognosis is and ask specific words and phrases that led them to believe so. This is an effort to inform clinicians regarding these conversations. Secondly, we will conduct a systematic review as follows and put together the medical ethics behind not doing technically possible surgery when the outcome is not expected to be good, using the methodology of systemic review of reasons for ethical principles developed by the ethics and surgery departments over at Duke. I encountered these folks during fellowship. I learned a lot from them. As you can tell, I'm at the very beginning of my academic journey. I invite anyone who has a question, a suggestion, or a collaboration that does not fit into the time constraint of this forum to please reach out to me. I'll be happy and excited to hear from you. Oh, and by the way, there's an H in the middle of my last name. Thank you so much, everyone, and thank you for being my very, very best audience.
Thanks, Dr. Nohra. My question has to do with, give us some observations or recommendations about alignment of goals, principles, which is, often in my own experience, I find a little bit of disconnect between what an intensivist, what a surgeon, what a patient and their family have in their minds. And how does one bridge those different gaps in the goals?
That's an incredibly good question because the answer is nuanced. What I would do is I would listen to everyone. I would see what they're saying, why they're saying it, and exactly what they think the outcome of said set of actions is going to be. Pick up the phone and talk to a surgeon if I was the intensivist. Or if I was a surgeon, I'd pick up the phone and talk to the intensivist. What I would want to know is what they're thinking they want to do and how they think they're going to help, that's going to help the patient. And also, what are the potential burdens of treatment? I would then take that information and listen to the families. I'd start with generalities. I'd want to know what that person's life is like, what they want to maintain in that life. And, everybody wants all of everything, no pain, no functional disability, and living for a very long time. But in most cases, if you talk to someone long enough, you find what they actually value, like what decisions they've made in the past, how they relate to their life, to their surroundings. And then based on that, you can make a recommendation based on what's most important to them. And everybody has a good idea for how to help the patient. The question is, what's the best idea for that patient, this particular patient with a particular set of values?
Yeah, thank you for your presentation. I think you touched this point briefly in your presentation, but I would like to enhance this part. I think personally, whenever I had any issue, let's say, in this kind of situation has been when there has not been a good communication between intensive care attending and, for example, the surgeon attending. Because I think that people get two different, information. Maybe the surgeon that did surgery spoke with the patient before surgery, so it knows exactly what was the conversation or the prognosis or so on. So I would like to have from you, where do you think, how can we improve this sort of interprofessional communication between attending before maybe to go to discuss with the family? That's, I think is important for family in this situation, being, seeing that the attending in the hospital, the palliative care are, they have a sort of common vision of the problem. I think one of the problems when they feel that there is a different view.
That's an incredibly excellent question. What the patient does not want to see is a split in their provider team. Best way to, there are multiple things that can be addressed at different levels, like from an integrative way to address this problem, because it's a large problem that one side can't necessarily fix on their own. So things that could help. So if the surgeon would document their exact conversation about exactly why they're doing the surgery and what they would hope to achieve in clinic, that would help the intensivist understand. And the other thing is availability. So everybody's busy in the OR or on the surgical service. Sometimes the best thing that can happen is for the surgeon to call the intensivist and tell them what they expect to achieve. And at that point, the intensivist can say, well, we were hoping to achieve X, Y, and Z, but right now the patient has deteriorated in X, Y, and Z way, and I don't think that's actually going to get there. And get on the same page as to where we are with the patient and how and whether or not we think we're going to get to where we thought we were going to get. And the other thing is including the specialists in the palliative care conference or in the update conference. So we may start on the same page, but we may end up in different pages based on the patient's progress, or we may not have understood each other in the first place. And those are all invitations for better communication and multiple ways to reach that.
Yes, Jeff, Dr. Cleveland.
Fantastic presentation. I think one of the things we struggle with in our realm is the essence of time, and that time being, obviously nobody wants a tracheostomy, nobody wants dialysis, nobody wants this stuff. But in our world, it's like you can get to the end goal of probably having at least a reasonable chance, and what's reasonable, 30, 50% of recovery with these things. So how do you nuance those decisions? Because the most frustrating thing for me is doing incredibly high risk operation, aortic dissection, and then even though things go great, they're on dialysis, and you're trying to tell someone who's 58, this is going to probably be for a month or 6 weeks, but you'll get back to okay, and the family comes and says, he didn't want any of this, turn it all off. So how do you deal with those situations?
That's a really tough call. If I were the person who had done the surgery, I would be like, so I completely understand where that's coming from. Now, I would I would say that it's important to know that when you get to a certain point, there is a certain point of no return. Good intensivist usually knows when you're there. A better intensivist knows when you're getting there. And so having that conversation again of where we are is helpful. The other thing is we should have shared goals. So for example, the surgeon should be able to push the goalpost to say, I know, things are getting worse in X, Y, and Z, but I think, for example, when their liver picks up, they're going to come off dialysis. Like these kinds of intelligent conversations, the intensivist is not going to think they know everything, at least again, not a good one. So if you talk to the intensivist and figure out what can be achieved, they might help you achieve it. Also, if you've had the exposure with the intensivist and the families, you might see that what you hoped would happen from day 1 to day 2, almost similar to the best case scenario, is actually not happening. And then there's, this is an entirely different talk, but we could talk about PICS. Sometimes saving the life is not worth actually saving the life, as in their outcomes after discharge are really not what you think they would be or what you would hope they would be. So there's a balance. There's definitely 2 sides of that coin, and every patient, every case is going to have a different balance of which side we're going to pick. And I do agree with you, though. I don't think these decisions should be made unilaterally. I think they should always involve the surgeon, especially when high-risk surgery was involved.
Okay, last question, Dr. Robbins.
So congratulations. This is a great topic to wrestle with. We've been working on multidisciplinary decision-making conferences. And I think that there's a fine line between being a group that's saying, we're not going to offer you the best care, right? Having the patient and the family feel like you're withholding the care from them. And then being a group that's saying, no, we're really going to align this in your best interest. And this is the best thing for you. And it's very hard to get at that. Do you have any advice for us as we move forward?
I think before getting in that room with the patient, it'd be important to get together with all of the important players. You don't want to walk in the room and someone to give the impression that something can be offered, but is being withheld. I think everybody needs to kind of agree that while this is technically possible, the outcomes of that are poor to the point where we're not going to offer it. Or it is, the outcomes are poor, but maybe, so we're going to offer it in exactly that way. And you'd be surprised. Patients usually make that decision for you. When you preface things with the exact pros and cons rather than them detecting that you want to offer it, but you're not, if you give them the information, they tend to use it, the actual information of you have, for example, a 20% chance of this helping you, an 80% chance of X, Y, Z, Y happening.
Just a couple. So, the palliative services, surgical, and also the palliative team here, I think are really wonderful. And they've helped me out of some tough situations that went either direction in terms of, going on with treatment and being aggressive versus saying, enough is enough. And, the patient made the call that he or she does not want to go anymore. My second point, and this is just a very small part of palliative care, but we're starting an inpatient hospice service. And it's actually live for a couple of different teams right now, but it's going to be more generalized. And it's a mechanism where if you have a patient, is in their last couple of days and you want to switch your focus from doing things to making sure the patient is as comfortable as possible and in the right environment, you can actually keep that patient in the same bed and switch them to inpatient palliative care. And the attending becomes the palliative care team. And it's really a terrific service. So keep your eyes and ears open. That's coming online. And it also has other benefits besides, obviously taking the best care of the patient, but it also changes how, Vizient looks at mortality. So keep tuned. I want to congratulate you for a great presentation. Thank you very much. Thank you.